This video is on gliomas. Gliomas are the most common primary brain tumor. To understand gliomas, let's first look at the four main types of glial cells: astrocytes, oligodendrocytes, Schwann cells, and microglia. Astrocytes provide structural support for neurons and contribute to the blood-brain barrier. They also maintain electrolyte balance and repair damaged tissue. Finally, astrocytes guide neuron migration during development. Oligodendrocytes and Schwann cells form the myelin sheath in the central nervous system and peripheral nervous system, respectively. Finally, microglia are the resident macrophages of the CNS. Now let's look at what happens when glial cells become cancerous. Astrocytomas are located usually in the cerebral cortex and crosses the midline and can be low-grade or high-grade. Low-grade tumors have isocitrate dehydrogenase mutations and intact 1p19q. In contrast, grade 4, known as glioblastoma multiforme, are very aggressive and do not have an intact 1p19q mutation. In contrast, oligodendrocytomas are calcified tumors of oligodendrocytes and are in the white matter. It usually affects the frontal lobe and hence presents with mood or personality changes and may present with seizures. So what are the signs and symptoms of a glioblastoma? Headache is very common and can be tension or migraine-like in nature. It is worse on the side of the tumor. Seizures are also common with glioblastomas because the neuronal activity and conduction is impacted if we think back to the function of astrocytes. The location of the tumor will also give rise to corresponding focal deficits, such as motor weakness, sensory loss, and aphasia. This is, however, more common with lower-grade gliomas. There may also be cognitive dysfunction, such as memory issues or personality changes if the tumor is affecting the limbic system. As the tumors are a mass in the brain, it will also engender raised ICP and relevant signs and symptoms. In terms of investigations, it is important to check for metastases with the normal workup, but the key diagnostic investigation is brain MRI. Low-grade astrocytomas are T2 flare, hyperdense, and vasogenic edema is usually absent. Most are non-enhancing and are common in the cerebral cortex or thalamus in adults. In contrast, high-grade tumors are hyperdense on T1. They are ring-enhancing along the margins with central lack of enhancement, indicating necrosis. Vasogenic edema is present, and there is increased blood flow and volume. Oligodendrocytes, as we mentioned before, appear calcified and in the frontal lobe. Ependymal cell tumors, usually in kids, and are commonly arise in the fourth ventricle, leading to hydrocephalus. Management can be broken down into supportive and definitive. Supportive measures include dexamethasone and mannitol because it reduces focal symptoms and vasogenic edema. Levetiracetam can be given for seizures. Definitive treatment is surgical resection, if possible, or radiotherapy, but this has more complicated recovery and side effects, so may not be appropriate in a palliative setting. Thank you for watching. If you learned something, please tell a friend who may also find it useful. Don't forget to follow us on Instagram at MidnightMed1200.